Okay, so I have dyslexia, and I'm now going to read the entire Wikipedia page of dyslexia. And I kind of suck at reading, but I guess we'll just have to overcome that. Okay, dyslexia. From Wikipedia, the free encyclopedia, that dyslexia, previously known as word blindness, is a learning disability, learning difficulty in the UK, that affects either reading or writing, or both. Different people are affected to different degrees. Problems may include in spelling words, reading quickly, writing words, sounding out words in the head, pronouncing words when reading aloud, and understanding what one reads. Often these difficulties are first noticed at school. The difficulties are involuntary, and people with this disorder have a normal desire to learn. People with dyslexia have higher rates of attention deficit hyperactivity disorder, ADHD, developmental language disorders, and difficulties with numbers. Dyslexia is believed to be caused by the interaction of genetic and environmental factors. Some cases run in families. Dyslexia that develops due to a traumatic brain injury, stroke, or dementia is sometimes called acquired dyslexia or alexia. The underlying mechanisms of dyslexia result from differences within the brain's language processing. Dyslexia is diagnosed through a series of tests of memory, vision, spelling, and reading skills. Dyslexia is separate from reading difficulties caused by hearing or vision problems, or by insufficient teaching opportunities to learn. Treatment involves adjusting the teaching methods to meet the person's needs. While not curing the underlying problem, it may decrease the degree or impact of symptoms. Treatments targeting visions are not effective. Dyslexia is the most common learning disability and occurs in all areas of the world. It affects 3 to 7% of the population. However, up to 20% of the general population may have some degree of symptoms. While dyslexia is more often diagnosed in boys, this is partially explained by a self-fulfilling referral bias among teachers and professionals. It has even been suggested that condition affects men and women equally. Some believe that dyslexia is best considered as a different way of learning, with both benefits and downsides. Classification. Main article, pure alexia. Dyslexia is divided into developmental and acquired forms. Acquired dyslexia occurs subsequent to neurological insult, such as traumatic brain injury or stroke. People with acquired dyslexia exhibit some more signs or symptoms of the developmental disorder, but require different assessment strategies and treatment approaches. Pure alexia, also known as agnostic alexia or pure word blindness, is one of the forms of alexia, which makes up the peripheral dyslexia group. Signs and symptoms. In early childhood, symptoms that correlate with a later diagnosis of dyslexia include delayed onset of speech and lack of phonological awareness. A common myth closely associates dyslexia with mirror writing and reading letters or words backwards. These behaviors are seen in many children as they learn to read and write, and are not considered to be defining characteristics of dyslexia. School-age children with dyslexia may exhibit signs of difficulties in identifying or generating rhyming words or counting numbers of syllables in words, both of which depend on phonological awareness. They may also show difficulties in segmenting words into individual sounds, such as sounding out the three sounds of k, et, in, cat, or may struggle to blend sounds indicating reduced phonetic awareness. Difficulties with word retrieval or naming things is also associated with dyslexia. People with dyslexia are commonly poor spellers, a feature sometimes called dysorthographia, or dysgraphia, which depends on the scale of orthographic coding. Problems persist into adolescence and adulthood and may include difficulties with summarizing stories, memorization, reading out loud, or learning foreign languages. Adults with dyslexia can often read with good comprehension, though they tend to read more slowly than others without a learning difficulty, and perform worse in spelling tests or when reading nonsense words. A measure of phonological awareness. Associated conditions. Dyslexia often co-occurs with other learning disorders, but the reasons for this comorbidity have not been clearly identified. These associated disabilities include dysgraphia, a disorder involving difficulties with writing or typing, sometimes due to problems with eye-hand coordination. It can also impede direction or sequence-oriented processes, such as tying knots or carrying out repetitive tasks. In dyslexia, dysgraphia is often multifactorial due to impaired letter writing automaticity, organizational and elaborative difficulties, and impaired visual word forming, which makes it more difficult to retrieve the visual picture of words required for spelling. Attention hyperactivity disorder, a disorder characterized by problems sustaining attention hyperactivity or acting impulsively. Dyslexia and ADHD commonly occur together. Approximately 15% or 12 to 24% of people with dyslexia have ADHD, and up to 35% of people with ADHD have dyslexia. Auditory processing disorder, a listening disorder that affects the ability to process auditory information. This can lead to problems with auditory memory and auditory sequencing. Many people with dyslexia have auditory processing problems and may develop their own logographic cues to compensate for this type of deficit. Some research suggests that auditory processing skills could be the primary shortfall in dyslexia. Developmental coordination disorder, a neurological condition characterized by difficulties in carrying out routine tasks involving balance, fine motor control, and kinetic coordination. Difficulties in the use of speech sounds and problems with short-term memory organization. Causes. Researchers have been trying to find the neurological basis of dyslexia since the condition was first identified in 1881. For example, some have tried to associate the common problem among people with dyslexia of not being able to see letters clearly to abnormal development of their visual nerve center. Neuroanatomy. Neuroimaging techniques such as functional magnetic resonance imaging, otherwise known as fMRI, and positron emission tomography have shown a correlation between both functional and structural differences in the brain of children with reading difficulties. Some people with dyslexia show less activation in the parts of the left hemisphere of the brain involved with reading, such as the inferior frontal gyrus, inferior parietal lobule, and the middle ventral temporal cortex. Over the past decade, brain activation studies using PETs to study language have produced a breakthrough in the understanding of the neurological basis of language. Neural basis for the visual lexicon and auditory verbal short-term memory components have been proposed, with some implications that the observed neural manifestations of developmental dyslexia in task-specific, i.e. functional rather than structural, fMRIs of people with dyslexia indicate an interactive role of the cerebellum and cerebral cortex, as well as other brain structures in reading. The cerebellar theory of dyslexia proposes that the impairment of cerebellum-controlled muscle movements affects the formation of words by the tongue and facial muscles, resulting in the fluency problems that some people with dyslexia experience. The cerebellum is also involved in the automation of some tasks such as reading. The fact that some children with dyslexia have motor task and balance impairments could be consistent with the cerebellar role in their reading difficulties. However, the cerebellar theory has not been supported by controlled research studies. Genetics. Research into potential genetic causes of dyslexia has its roots in post-autopsy examination of the brains of people with dyslexia. Observed anatomical differences in the language center of such brain include microscopic cortical malformations known as ectopias, and more rarely vascular micro malformations and microglias in a smaller than usual size for the gyrus. The previously cited studies and other suggest that abnormal corneal development presumed to occur before or during 6 months of the fetal brain development may have been caused by the abnormalities. Abnormal cell formation in the people with dyslexia have also been reported with non-language cerebral and subcortical brain structures. Several genes have been associated with dyslexia, including DCDC2 and KIAA0319, or chromosome 6, and DYX1C1, or chromosome 15. Gene-environment interaction. The contribution of gene-environment interaction to reading disability has been intensely studied using twin studies, these which estimate the proportion of variance associated with a person's environment and proportion associated with their genes. Both environmental and genetic factors have appear to contribute to reading development. Studies examining the influence of environmental factors such as parental education and teaching quality have determined that genetics have greater influence in supportive rather than less optimal environments. However, more optimal conditions may allow those genetic risk factors to account for more of the variance in outcome because the environmental risk factors have been minimized. Just a quick note, I have no clue what I just read. I don't understand anything of it. Or something about twins and environment, but that's all I got out of it. Anyway, I've got so much more to read. As environment plays a large role in learning and memory, it is likely that epigenetic modifiers play an important role in reading ability. Measures of gene expression, histone modifications, and methylation in the human periphery are used to study epigenetic processes. However, all of these have limitations in the extrapolation of results for application to the human brain. Language. The orthographic complexity of a language directly affects how difficult it is to learn and read it. English and French have comparatively deep phonetic and orthographies within the Latin alphabet and writing system. Their complex structures employing spelling patterns on several levels. Letter-sound correspondence, syllables, and morphemes. Language such as Spanish, Italian, Finnish primarily employ letter-sound correspondence, so-called shallow orthographies, which makes them easier to learn with people with dyslexia. Lithographic writing systems, such as Chinese characters, have extended symbol use. These also pose problems for dyslexic learners. Hesiology. For most people who are right-hand dominant, the left hemisphere of their brain is more specialized for language processing. With regards to the mechanisms of dyslexia, fMRI studies suggest that this specialization is less pronounced or absent in people with dyslexia. In other studies, dyslexia is correlated with anatomical differences in the corpus callosum, the bundles of nerve fibers that connect the left and right hemispheres. Data via diffusions, tensor MRI, indicates changes in the connectivity or in the gray matter density areas related to reading and languages. Finally, the left inferior frontal gyrus has shown differences in phonological processing in people with dyslexia. Neuropsychological and imaging producers are being used to ascertain phenotypic characteristics in people with dyslexia, thus identifying the effects of genetic-related genes. Dual route theory. The dual route theory of reading aloud was first described in the early 1970s. This theory suggests that two separate mental mechanisms, or cognitive routes, are involved in reading aloud. One mechanism is the lexal route, which is the process whereby skilled readers can recognize known words by sight alone through a dictionary lookup procedure. The other mechanism is the non-lexal or sublexal route, which is a process whereby the reader can sound out a written word. This is done by identifying the word's constituent parts, letters, phonements, graphements, and applying knowledge of how these parts are associated with each other. For example, how a string of neighboring letters sound together. The dual route system could explain the different rates of dyslexia occurring between different languages, e.g. the consistency of phonological rules in the Spanish language could account for the fact that Spanish-speaking children show a high level of performance in non-word reading when compared to English speakers. Diagnosis. Dyslexia is a heterogeneous dimensional learning disorder that impairs accurate and fluent word reading and spelling. Typical but not universal features include difficulties with phonological awareness, inefficient and often inaccurate processing of sound in oral language, and verbal working memory deficits. Dyslexia is a neurodevelopmental disorder subcategorized in diagnostic guides as a learning disorder with impairment in reading. ICD-11 prefixes developmental to learning disorder. DSM-5 uses specific. Dyslexia is not a problem with intelligence. Emotional problems often arise secondary to learning difficulties. The National Institute of Neurological Disorders and Stroke describes dyslexia as difficulty with phonological processing, the manipulation of sound, spelling, and/or rapid verbal responding. The British Dyslexia Association defines dyslexia as a learning difficulty that primarily affects the skills involved in accurate and fluent word reading and spelling, and is characterized by difficulties in phonological awareness, verbal memory, and verbal processing speed. Phonological awareness enables one to identify, discriminate, remember working memory, and mentally manipulate the sound structure of language. Phonements, on-site rim segments, syllable and all words. Assessment. The following can be done to assess for dyslexia. Apply a multidisciplinary team approach involving the child's parents and teachers, school psychologist, pediatrician, and, as appropriate, speech and language pathologist, speech therapist, and occupational therapist. Gain familiarity with the typical ages children reach various general developmental milestones and domain-specific milestones such as phonological awareness, recognizing rhyming words, identifying the initial sounds in words. Do not rely on tasks exclusively. Careful observation of the child in school and home environments and sensitive, comprehensive parental interviews are just as important as tests. Look at the empirically supported response to intervention RTI approach, which involves monitoring the process of a group of children through a program of intervention rather than undertaking a statistic assessment of their current skills. Children with the most need are those who fail to respond to effective teaching, and they are readily identified using this approach. Oh my god, why is it so much? I'm gonna take a quick break. Okay, I'm getting progressively more tired from reading this, and I have no idea how much I still have to read. Oh no, I can see it right here. I'm about halfway. Okay, assessment tests. There is a wide range of tests that are used in clinical and educational setting to evaluate the possibility of dyslexia. If initial testing suggests that a person might have dyslexia, such tests are often followed up with a full diagnostic assessment to determine the extent and nature of the disorder. Some tests can be administered by a teacher or a computer. Others require specialized training and are given by psychologists. Some test results indicate how to carry out teaching strategies. Because a variety of different cognitive, behavioral, emotional, and environmental factors should all contribute to difficulties learning to read, a comprehensive evaluation should consider these different possibilities. These tests and observation can include general measure of cognitive abilities such as the Wechsler Intelligence Scale for Children, Woodlock-Johnson tests of cognitive abilities, or Stanford Binet intelligence scales. Low general cognitive ability would make reading more difficult. Cognitive ability measures also often try to measure different cognitive processes such as the verbal, nonverbal, and spatial reasoning, working memory, and processing speed. There are different versions of these tests for different age groups. Almost all of these almost all of these, require additional training to give a score correctly and are done by psychologists. According to Mather and Schreiner, 2015, a confirmatory profile and/or pattern of scores on cognitive tests confirming or ruling out reading disorder has not been identified. Screening or evaluation for mental health conditions, parents and teachers can complete rating scales of behavioral checklist to gather information about the emotional and behavioral functioning for younger people. Many checklists have similar versions for parents, teachers, and younger people old enough to read reasonably well, often 11 years and older, to complete. Examples include the Behavioral Assessment System for Children and the Strengths and Difficulties Questionnaire. All of these have nationally representative norms, making it possible to compare the level of symptoms to what would be typical for the younger person's age and biological sex. Other checklists link more specifically to psychiatric diagnosis, such as Vanderbilt ADHD rating scales or the Screen for Child Anxiety Related Emotional Disorders. SCARED. Screening using brief tools that are designed to catch cases with a disorder, but often they give false positive scores for people who do not have a disorder. Screeners should be followed up by a more accurate test or a diagnostic interview. As a result, depressive disorders and anxiety disorders are 2-3 times higher in people with dyslexia, and attention hyperactivity disorder is more common as well. Review of academic achievements and skills. Average spelling/reading ability for the dyslexic is a percentage ranking less than 16, well below average, well below normal, in addition to reviewing grades and teacher notes. Standardized test results are helpful in the evaluating process. These include group-administered tests, such as the LOA test of educational development, Iowa, lowercase l and uppercase I blend together, that a teacher may give to a group or whole classroom of younger people at the same time. They could also include individually administered tests of achievement, such as the wide range achievement test or the Woodcock-Johnson, which includes a set of achievement tests. The individually administered tests require more specialized training. Screening. Screening procedures seek to identify children who show signs of possible dyslexia. In the preschool years, a family history of dyslexia, particularly in biological parents and siblings, predicts an eventual dyslexia diagnosis better than any test. In primary school, ages 5 to 7, the ideal screening procedure consists of training primary school teachers to carefully observe and record their pupils' process through the phonic curriculum and thereby identify children progressing slowly. When teachers identify such students, they can supplement their observation with screening tests such as phonetics screening check used by United Kingdom schools during year 1. In a medical setting, child and adolescents psychiatric MS Tsambira emphasizes that GIFN, I don't know why it's, I don't know what's that. Given the high prevalence of developmental disorders in school-aged children, all children seen in clinics should be systematically screened for developmental disorders. Irrespective of the presenting problems. Chambra recommends screening for developmental disorders, including dyslexia, by conducting a brief developmental history, a preliminary psychological developmental examination, and obtaining school reports regarding academic and social functioning. Management. True, the use of compensation strategies, therapy and educational support individuals with dyslexia can learn to read and write. There are techniques and technical aids that can help to manage or conceal symptoms of the disorder, reducing stress and anxiety. Reducing stress and anxiety can sometimes improve written comprehension. For dyslexia, intervention with alphabet writing systems. The fundamental aim is to increase the child's awareness of correspondence between graphemes, letters, and phonemes, sounds, and to relate these to reading and spelling by teaching how sounds blend into words. Reinforcing collateral training focused on reading and spelling may yield long-lasting gains than oral phonological training alone. Early intervention can be successful in reducing reading failure. Research does not suggest that specifically tailored fonts such as Dyslexie and Open Dyslexic help with reading. Children with dyslexia Children with dyslexia read text set in regular fonts such as Times New Roman and Arial just as quickly, and show a preference for regular fonts over specifically tailored fonts. Some research has pointed to increased letter spacing to be beneficial. There is currently no evidence showing that music education significantly improves reading skills of adolescents with dyslexia. There is some evidence from a RCT that atomoxetine might be helpful for dyslexic with or without ADHD. Prognosis. Dyslexic children require special instruction for word analysis and spelling from an early age. The prognosis, generally speaking, is positive for individuals who are identified in childhood and receive support from friends and family. The New York educational system, NYED, indicates a daily uninterrupted 30-minute block of instruction in reading and instruction in phonetic awareness, phonetics, vocabulary development, and reading fluency, also to improve the individual's reading ability. Epidemiology. The prevalence of dyslexia is unknown, but it has been estimated that as low as 5% and as high as 17% of the population dyslexia is diagnosed more often in males. There are different definitions of dyslexia used throughout the world. Further differences in writing system may affect development of written languages ability due to the interplay between auditory and written representations of phonemes. Dyslexia is not limited to difficulties in converting letters to sounds, and Chinese people with dyslexia may have difficulties converting Chinese characters into their meanings. The Chinese vocabulary uses logographic, monographic, and non-alphabet writing, where one character can represent an individual phenomenon. The phonological processing of hypotheses can attempt to explain why dyslexia occurs in a wide variety of languages. Furthermore, the relationship between phonological capacity and reading appears to be influenced by Okay, almost done. History. Oh, my knee! History. Dyslexia was clinically described by Oswald Burken in 1881, but the term dyslexia was coined in 1883 by Rudolf Berlin, an ophthalmologist in Stuttgart. He used the term to refer to the case of a young boy who had severe difficulties learning to read and write, despite showing typical intelligence and physical abilities in all other respects. In 1896, W. Pringle Morgan, a British physician from Seaford, East Sussex, published a description of a reading-specific learning disorder in a report to the British Medical Journal titled Congenital Word Blindness. The distinction between phonological versus surface types of dyslexia is only descriptive and without any etiological assumption as to the underlying brain mechanisms. However, studies have alluded to the potential difference due to variation in performance. Over time, we have changed from the intelligence-based model to the age-based model in terms of those with dyslexia. Society and culture. As is the case with any disorder, society often makes an assessment based on incomplete information. Before the 1980s, dyslexia was thought to be a consequence of education rather than a neurological disability. As a result, society often misjudges those with the disorder. There is also sometimes a workplace stigma and a negative attitude towards those with dyslexia. If instructions of a person with dyslexia lack the necessary training to support a child with conditions, there is often a negative effect on the student's learning participation. Since at least the 1960s in the UK, children diagnosed with developmental dyslexia have consistently been from privileged families, although half of persons in UK have significant reading difficulties. Very few have been evaluated for dyslexia. Access to some special education resources and funding is contingent upon having a diagnosis of dyslexia. As a result, when the Stafford Shrine and Warwick Shrine proposed in 2018 to teach reading to all children with reading difficulties, using techniques proved to be successful for most children with a diagnosis of dyslexia without first requiring families to obtain an official diagnosis. Dyslexia advocates and parents of children with dyslexia were fearful that they were losing a privileged status. Stigma and success. Due to the various cognitive processes that dyslexia affects and overwhelming societal stigma around the disability, individuals with dyslexia often employ behaviors of self-stigma and perfectionistic self-presentation in order to cope with their disability. The perfectionist self-presentation is when an individual attempts to present themselves as the perfect ideal image and hides any imperfections. This behavior presents a serious risk as it often results in mental health issues and refusal to seek help for their disability. Research. Most dyslexia research relates to alphabetic writing systems and especially to European languages. However, substantial research is also available regarding people with dyslexia who speak Arabic, Chinese, Hebrew, or other languages. The outward expression of individuals with reading disabilities and regular poor readers is the same in some respects. Okay, yes, I'm done.